Welcome to our Shock Talk on Frostbite by Jamie Martell and Ashley Otto. Jack, Sam, and Jane are teenagers driving on the Missouri River after it was frozen over and their car went through the ice. All three were taken to the emergency department. Jack, patient 1, has cool pink skin on hands and feet. Sam, patient 2, has blisters on several fingers and toes. And Jane, patient 3, has 3 black toes on one foot and 2 black toes on the other as she lost her shoes in the river. All of the patients are conscious with stable vitals, but they are all complaining that they are cold and in a lot of pain. Pathophysiologic process of frostbite includes the tissue destruction of frostbite is due to both immediate cold-induced cell death and more gradual development of reperfusion-related localized inflammatory processes and tissue ischemia. When exposure to subfreezing temperatures occurs, ice crystals form extracellularly. If the freezing occurs faster, ice crystals may form inside the cells. Fluid and electrolyte fluxes cause lysis of cell membranes and therefore cell death. The inflammatory process caused by thromboxane A2, prostaglandin, F2 alpha, bradykinins, and histamine occurs, causing ischemia and necrosis. Initial cellular damage and following inflammatory processes are worsened by thawing followed by refreezing. First-degree frostbite has no cyanosis, is superficial and characterized by a central area pallor and anesthesia of the skin with some edema. Patient 1 has these symptoms. Second-degree frostbite has cyanosis that is isolated to the distal phalanx. Soft tissue amputation and nail sequelae is predicted. It is recognized by the large blisters with clear fluid, edema, and erythema. The blisters may have eschar, which will later slough off to healthy granulation tissue with no tissue loss. These symptoms correlate with patient 2. Third-degree frostbite has intermediate and proximal phalangeal cyanosis. Bone amputation is predicted of the digit and functional sequelae. The injury is deep and blisters are smaller, hemorrhagic, and proximal. The skin has black eschar that is formed in 1 to several weeks. This finding is consistent with the third patient. Fourth-degree frostbite involves the carpal and tarsal bones. Bone amputation is predicted. It extends into the muscle and bone and involves complete tissue necrosis. Mummification occurs in 4 to 10 days. Diagnosis is generally made on clinical findings, such as injury, signs and symptoms, and history. Bone scanning might be helpful to understand extent of frostbite and its prognosis. Frostbite is a morbidity, not a mortality, so more immediate life threats like hypothermia should be addressed first. Plain radiographs are not useful initially, except for trauma-related fractures. This can be used to identify bony destruction weeks to months after the injury. Angiography may be used to identify patients that are suitable for thrombolytic therapy, as it visualizes the microcirculation after the injury. Bone scan is used to identify candidates for thrombolytic therapy, predict long-term viability of affected tissue, in the case of debridement or amputation while preserving healthy tissue. It should be used immediately after thawing, if candidate for TPA. It may also help to avoid surgical intervention and can also help monitor therapy. Single photon emission CT is used to identify non-salvageable tissue and has more accurate determination of extent of tissue destruction than conventional bone scan. Rapid rewarming is suggested as long as there is no risk for refreezing, as this and slow rewarming can cause more tissue damage. There are dangers involved in rapid rewarming, though. Cells starved of nourishment due to injury will soon die. These dying cells stimulate the release of histamine, causing the blood vessels to dilate, which increases blood supply and extra nutrients to help repair the damaged tissues. With an increase in blood supply, the capillary walls become much more permeable, and protein and inflammatory substances are pushed into the area, causing swelling. Muscle spasm may also occur, causing the muscle to contract, helping prevent further movement. This may restrict blood flow and place more pressure on nerve endings, leading to increased pain. Do not apply warmth directly to skin, as it can cause burns due to decreased sensation. There is also a risk for clots with rewarming. TPA should be considered when rewarming due to this. Potential complications. Short-term complications of frostbite include infection, gangrene, tetanus, and acute compartment syndrome, although that is rare. Patient 1 with a grade 1 injury can expect no amputation or lasting effects. Throbbing pain may occur after rewarming with any frostbite injury for weeks or months. Sensitivity to cold, increased risk of developing frostbite again, changes in skin and color, long-term numbness, intermittent paresthesia from ischemic neuritis, loss of muscle dexterity, burning, electric shock sensation, joint stiffness, and excessive sweating are also potential complications. Scarring, tissue atrophy, arthritis, and peripheral neuropathy are also potential long-term complications. Vasospasm due to peripheral neurovascular injury is common and may be permanent. The severity of these complications depends on the severity of the injury and the stage of the frostbite. Patient 2 with grade 2 injuries might have long-term complications leading to tissue and fingernails being destroyed. Patient 3 had a stage 3 frostbite injury. This included a lesion near body part. Long-term complications include autoamputation, loss of function, and complications of autoamputation, such as infection. Being a teenager, this patient is still growing and may experience some growth defects and bony abnormalities as a result of the injury. Stage 4. With grade 4 frostbite, limbs can be lost. Sepsis and systemic problems are expected. It is also important to avoid cold exposure for at least 6 months to prevent further damage. 3 takeaways to include: 1. Know grading of frostbite. Know the signs, symptoms, and clinical manifestations of each grade. 2. Know the workup, not for diagnosis but for prognosis and extent of injuries. 3. Know the complications to provide a better outcome for your patients. Thank you.